All right.
Good morning, everyone. Thanks for joining us today. My name is Luke Walber, and I'm a graduate student in the Master's in Public Health program at Southern Illinois University. Our webinar today is part of the Rural Opioid Prescriber Training Program, and as a part of this program, SIU's Medical School is offering opioid prescriber resources through webinars, continuing education credits, providing guidelines or alternatives to opioids and pain relief. This is one of several webinars that the Rural Opioid Prescriber Training Program will host this year, and we hope you can attend future events as well. This morning, we have the pleasure of having Jack Teitelman, the CEO of Titan Group DEA Compliance Experts, to speak to us about opioid prescribing in veterinary medicine. Jack has decades of experience working for the Department of Justice and the Drug Enforcement Administration. He has won numerous awards and commendations in his field while gaining extensive knowledge in opioid and other drug-related investigations. Today, Jack will be presenting Effects of the Opioid Epidemic in Veterinary Medicine. Again, thank you everyone for joining us today, and now I'll pass it over to Jack.
Thank you, Luke. Let me go ahead and share my screen so we can get started. You got that? Everybody got it? Good to go. All right. Good morning, everybody. This is going to be a webinar on the effects of the opioid epidemic in veterinary medicine. My name is Jack Teitelman. As Luke said, I'm the Titan Group founder and CEO. I was a former DEA special agent and supervisor for 26 years. Pretty much nothing under the sun that I haven't seen, done, had some interaction with any type of drug controlled substance from the legal to illegal. So this has been pretty much a whole a quarter century of my life has been invested in the drug world and in drug investigations, and now in drug diversion and education and training for what you guys are going to need when you end your education and end up in the veterinary field in your chosen profession of whatever you choose to do. You know, what makes us special? Why do we understand DEA compliance better than we think anybody else in the country? Because we are DEA. We're all of us were former DEA either agents or diversion investigators. The diversion investigators are the ones that will pay most attention to veterinarians and veterinary hospitals or facilities. So, because that is a civil oversight by the DEA. So, you know, what is it that that we do and you know that emulates and helps you with dealing with DEA and your state is the most important thing is training and education. One of the things that we have found since we've been working in the veterinary community is there's been an extreme lack of education when it comes to controlled substance management, when it comes to the understanding of controlled substances and their use in the veterinary sector, and how to deal with addiction, how to deal with those things that we have never had to really deal before. That's just been, you know, has attacked all of healthcare in the past 15, 20 years. Remediation, those are issues that you guys run into some type of issue in your hospital. There's been a theft, there's been unexplained losses. We don't know what's happening with the inventory. Those are things that have to be addressed and fixed, or come up with some solution that we can hand over to DEA, or that we can work towards, you know, having a solution in-house. Compliance audits and inspections, that's what we do. We'll come into your facility and we're going to do a mock DEA audit. We're going to try and stress and put as much pressure on the facility and shake the tree and see how much falls out. And of course, we're going to then have a support function where we work with everybody. We don't want our interactions with you guys in the future to be one-offs. We want to be part of your ethos. We want to work with you guys going forward, because there's always going to be some type of change or question or something that you guys are going to have to deal with. We've been working in the veterinary community, like I said, for at least the past 4 years. We've been in over 500 veterinary hospitals from New York to Hawaii. So there's nothing under the sun that we have not seen or done or had to deal with when it comes to veterinary medicine, and how veterinary medicine deals with controlled substances and the good and the bad. And I'll talk a little bit about all of that. I'm going to minimize this. It's in my way. Thank you. Okay. So what is it we're going to talk about today? These are our objectives. I'm going to talk about the opioid epidemic, where that opioid epidemic came from. You know, we're kind of in the third wave, probably headed into the fourth wave now that we've had the pandemic. We're going to talk about, DEA compliance. How does DEA compliance, overall fit into your management of opioids and then your understanding of that? What is drug diversion? How are you guys, going to understand that? What is it to look for? And it's something that all of you are going to probably run into to some extent. Drug diversion is drug theft. Drug shortages. You will soon find out that there are not opioids available like they used to be for the veterinary community. Some of the opioids production has been cut 50%, and that causes some issues. It causes over ordering, and we'll talk about a little bit about that. And then best practices. What is it that we can do to put you guys in the best foot forward that you can have success at DEA compliance? It's not hard, but it's easy for me to say that. It's really not rocket science, but it can turn into rocket science when things go bad. I'm going to play this little video, and hopefully you guys can hear it. You guys getting any audio on that?
No, there's no sound.
Okay, I don't know. So basically, I'll be the sound on this. This is a commercial that you normally would see, and it talks about how everything started with a pill. Everyone who was either I turned their ankle, as you can see, I was a young athlete, and that's how all of this started. Oops, I lost you guys for a second. This wasn't something that everybody, out of the blue just became. Oh, let me figure out how to get past this now. Oh, hold on one sec. There we go. Okay. So, that being said, where we're at today, because of the indiscriminate prescribing of doctors handing out pills like they were candy starting in the mid-90s, and that's where we're at. So that overabundance of prescribing by doctors who really should not have been in the pain medicine, that really everyone knew. Look, there's nobody out there in healthcare that's a doctor or anybody in medicine that does not realize that morphine is addictive. Morphine's not new. All of these drugs nowadays have morphine equivalents that we might get into a little bit at the end. But this was nothing new. This was a PR campaign. This was taking something, repackaging it up and saying, hey, we have a new tire. Look at this new tire. It's better than any tire that's ever been there before. And oh, by the way, it's not addicting. Of course, that wasn't true. And that's kind of put us on, the foot that where we're at today. And of course, this was front and center, and what we've seen in the news and what we've seen in social media, it's always on the human side of healthcare. But we all know that the effects have also, hit the veterinary community just as hard or maybe worse. And you heard me say that this went in 3 waves. The first wave was in the 90s. This is when that indiscriminate prescribing started. This is when the PR campaign of Purdue Pharma started. This is when they went out and they tried to sell a false narrative to every doctor out there that Oxycontin, which was their great blue pill, was not addictive. And quickly, we started to see that rise in Oxycontin use and just all opiate use that went from the 90s to the early 2000s. And eventually, people build up tolerances. Eventually, people need to move on to something stronger. And that's when people would start to transition from the pills to heroin. Some people can never make that transition. They don't want to put a needle in their arm, but they soon figured out that it was so expensive to continue buying pills. It was a lot cheaper to buy heroin, and addiction really doesn't care about price. You're going to end up using, that next stronger drug. And that's what happened. So we then had a period of time where we had transition from pills to heroin, and then all of a sudden fentanyl came onto the scene. Now, this isn't the same fentanyl that you guys will use or see when you're in the veterinary, because that is a manufactured fentanyl. It's different. But this is fentanyl that is illegal fentanyl. Most of it has come from China, being produced in Mexico, and then that stuff works its way into the United States. So now we have synthetic opioids. Now we have people that are becoming super users of opioids. We have people today that are purely fentanyl addicts, giant tolerances, to the extent that the current Narcan that we have on the street won't save someone that's had an OD on a synthetic. excuse me, very powerful synthetic, such as fentanyl or carfentanil, which is even stronger, which we see. And the only carfentanil you guys should maybe see will be in a zoo. Carfentanil is used to take down elephants. So, here's a brief statistic of the opioid epidemic and how it has affected your state in Illinois. These numbers really are not, not much different than they are across the country. When I started in law enforcement and was involved, in working on heroin cases, we looked at, it was an urban issue. People that were hooked on heroin were junkies. Today we don't classify them as, as that. Today it's an addiction issue. People, we now realize that addiction changes the brain forever. Those pathways that used to send signals, those are changed. So someone who's now has an addiction issue, we consider that a sickness just like we do blood pressure or diabetes, and they have to be treated for that for the rest of their life. Unless they're going to be able to go cold turkey, and that's a very difficult thing to do nowadays with opioids. So that was a little introduction of the opioid epidemic and why it's gotten us to where we're at. Now I'm going to talk about DEA compliance and why that is, why you should be concerned about DEA compliance. But, DEA compliance is your federal oversight for your controlled substances. And everyone that is a veterinarian, in order for them to technically practice veterinary medicine correctly, they have to get a DEA registration if they're going to order drugs and administer and dispense them under their DEA registration. So there's a lot of rules and regulations and policies that go along with that. And for the federal, your DEA registration and for the federal law, everything falls under in two places. It's the Code of Federal Regulations is number one. That is for Title 21 is under the Code of Federal Regulations that the DEA has, that they govern the food and drug policies that cover controlled substances. And for your purpose, it's Title 21, 1300 to end, but we're not going to worry about that. But just realize that DEA's function under Title 21 is both a law enforcement function and a civil function. So that civil function is where you guys are going to have your oversight with DEA. And their oversight is for 5 specific drug classes or schedules. And Schedule 1 is your illegal drugs. Of some of those, LSD, the methamphetamines, heroin, some of those will be tested. Some of those, we will find in some research facilities them doing testing on MDMA and LSD. Other drugs that now are starting to have use as we start, and cannabinoids, cannabis, those still fall under Schedule 1. Yet they don't have much medical value, although we're starting to see medical value. And then Schedule 2 are your opioids, 3, 4, and 5 are your benzos and your other drugs that you guys use. Now, remember, when DEA scheduled it, it's all about abuse potential. What is the medicinal value, and is it a danger? Is it a danger with serious side effects? And of course, we all know what happens with someone who either is not tolerant and uses an opioid. That's where we run into overdose issues and death. So when the DEA started and put together their controlled substance, the CSA, which is the Controlled Substance Act in 1970, this was supposed to be a closed loop of distribution, meaning that the minute these drugs are start to be manufactured and made and distributed and passed through the supply chain, there wasn't supposed to be anything leaking out. Well, unfortunately, during the opioid epidemic, we had many breaks in this closed loop of distribution, whether stuff was being stolen off the line in manufacturing, whether boxes were being stolen during distribution, whether the UPS guy or stuff was being stolen at what they call 3PL shipper locations, whether stuff, and then we get where it ends up in your facility and things start to disappear within the facility. All of that is the supply chain that DEA is responsible for. So it's from the minute stuff is produced to the minute it ends up in the animal's mouth. So some of the times when we're dealing with, DEA compliance issues, we run into a state that actually has a higher compliance standard for something. I'll give you one example will be the drug gabapentin. Gabapentin is federally not a controlled substance under Schedule 1 through 5. Yet it is now a controlled substance in, I believe, 8 states. So we have a responsibility to ensure that we're tracking that drug just as we're tracking the other controlled substances. So just be aware that although DEA is going to most of the time be your ultimate guide for how you will have success in handling controlled substances, there are certain things that we have to adhere to in the states. And some of them might be PMP, prescription drug monitoring issues that we have to send off. Some might be record keeping, where DEA says you only have to keep your paperwork for 2 years. Some states say 3 to 5. So we just have to, just make sure that that's something that you are, that you understand when you go into wherever you guys end up working. So storage, when you get to your, your next job or wherever you're going to end up, you're going to see many different examples of how drugs are being stored. What you see here is an example of what's called an automated dispensing cabinet. In the veterinary community, you will mostly see Cubex machines, although there are other machines out there, Pyxis, Omnicell, Medicast, there's other machines that do the same function. But mostly you will probably see a double locked box on a wall, some type of cabinet, maybe a safe. All of those, as long as it's a secure container, substantially constructed, those will all pass as secure storage. If you ask me, what is the thing that most people are going to fail at? What is it that, that people just can't seem to get right on a consistent daily basis? And that's record keeping. And it's probably the easiest function of your DEA compliance is keeping tracks of ins and outs. For some reason, people cannot seem to write clearly and concisely. Decimal points do make a difference. If you go from 0.01 to 0.001, that makes a gigantic difference. It makes a difference in what's being recorded. It also makes a difference. It could become a medication mistake, a medication error. I just dealt with a medication error this morning from one of our largest animal hospitals on the East Coast. It was a mistake, exactly what I just said. An animal was given double dose of methadone. So just realize that, what you're recording not only is going to be important for documentation purposes, because what goes into that logbook is your legal binding contract with the DEA to turn over. And what goes in it is what we turn, what you're going to be graded on. So crap in is crap out. So just be aware that when you are logging and you are making sure that, you're meeting those standards that you need to, it's not you that's going to have the issue with DEA, it's your doctor. It's the DEA registrant. And we need that doctor to ensure that we have a job. So it's our job to ensure that they don't get in trouble, by screwing up on the law books. So, what are those requirements? What is the doctor's requirements that they have to adhere to, and they have to have oversight responsibility to ensure that you guys are doing what you're supposed to be doing correctly. And of course, number one, it all starts with accountability. How often are you guys doing counts? Are you doing counts daily? Are you doing counts weekly? Or are you only waiting to do your counts, biennially, through the DEA requirement? We don't recommend that. We recommend that you at least you do your biennial inventory as a requirement from the DEA, that you have to do an absolute count of every controlled substances on beginning of business or close of business on a specific date within a 2-year period when you started your inventory. Sounds crazy, but it's real easy. The problem is people forget to do it. And if you forget to do your biennial inventory, the number one thing that DEA is going to ask for when they come to your facility is, I need your biennial inventory, because that gives them a starting point when they do their accountability audit when they come into your facility. Those records and control or lack of control of those records is going to make or break you. They have to be available and ready for the DEA when they show up on site. Your time to prepare and try and find things and reach out to your practice management software company to wonder why I can't find something or print out a report, that's not the time to do it. The time to do it is proactively, ahead of time, making sure that you can pass a DEA mock audit. That's what we do for a living. We go into facilities and we stress them. We do mock audits and inspections. And then, like I said, we shake the tree and see what falls out, and then we try and fix it. Inventory, You guys are going to live and die by your inventory, not just controlled substance inventory, but you guys are going to find out that your regular inventory, your flea and tick medication, your very expensive dog and cat food, that stuff's going to walk. 5-finger discount. It happens every facility we go to. I'm not going to opine on it. It's just, it's humans, human beings. They just can't seem, somebody in that office is going to take something. And if they're going to take food and if they're going to take flea and tick medication, they're probably also going to help themselves to self-medicate. Okay, so, regular internal audits, more the better, something that we have our clients doing at least on a weekly basis or at least once a month. When you heard me before saying that all your records need to be readily available for DEA to inspect, we call that, our ready retrievable file. We pre-populate a file with what we know exactly what DEA is going to require when they get to your facility. And you can see I put some of the examples in here: power of attorneys, that biennial inventory, copies of any inventories that you guys have done, your licenses and stuff like that. And anyone that works in the facility that has been granted authorization to work with controlled substances, they're going to need that too. If you don't give it to them, DEA is just they'll get it for you. Excuse me. So just realize that everyone that works with controlled substances has to be authorized. And that's mostly done by a simple background investigation. If you've had an arrest, if you've had a drug addiction issue, those are things that we need to let the doctor know so that we can figure out if this might not be the right job for you. Maybe there's something else in the hospital we can have you do instead of work alongside medicines that might be tempting. So, oops, what did I just do here? So when reconciliation is kind of what I was just getting at. Don't wait months. You want to reconcile at minimum weekly. And what does that mean? That means making sure your math is correct, going through your log books, ensuring that whoever, have a manager, someone in management goes through and make sure that all, the ins and outs are right. Mathematical errors will compound if you don't fix them. And, if you're not doing end of bottle reconciliation, meaning at the end of the bottle, you zero it out and you start again with a new bottle and you put that amount in. If you're just running what's called a perpetual inventory and you bought 5 gallons of something and you start with 5 gallons and you just run it down till you get out and then you put another 5 gallons in, those are a little more difficult to deal with. We need to deal with the bottles, and that's something you guys will learn a little bit more as when you get out to the field. But reconciling and making sure that your math is correct is important, because if you don't do that, you're going to fail. You're going to fail the inventory part of your audit when DEA comes in. And I can tell you that they don't. This is very serious. And if you have a record keeping issue that looks like you're just not keeping, having absolute control, you're going to get put on DEA probation, which is called a memorandum of understanding. They're throwing them out all the time now. There's more oversight now with what they call MOAs than there's ever been before. So that's what we deal with. We deal with DEA and the companies that need oversight. I was just on the phone with one this morning. It's not the end of the world. It's just that at this point, everybody now cannot screw up going forward. Look, if you're going to be in a facility that's going to be, boarding animals, there's going to be animals that are going to come in with medications, right? So those medications are end user medications. Those have already been given and dispensed, to that client. Those can no longer be used by you guys to treat that animal over a weekend. If it's very expensive cancer medication or some medications, that's very expensive, it's not easy to get, we can make exceptions for that. But if you have controlled substances in your facility that you can dose them out of over that weekend stay, we prefer that you do that and not try to take receipt of their of their drugs, because in a way that I've seen so many examples of their stuff coming in and then disappearing. If you're going to do it, take an inventory, make the person sign for it, make them count those drugs, only take the enough amount of pills for that visit. If they're only going to be there 2 days, take 4 pills. Don't take their whole bottle. Okay, so just remember, this custodial care medication, we don't want to get into that business. This is where you'll get accused of stealing, medication, specifically if it's something like tramadol. It's an older dog and, they've been on chronic pain medication for a long time. Well, either you take the minimal amount, sign for it, or you dose, directly out of your facility's, drug inventory. If you do run into the situation, if you have to do it, treat these drugs just as if you would treat any other drug. You're going to want to have a separate lockbox for your kennel area. You're going to want to have a separate logbook for that area. Take a picture of what you came in, so that way you guys can have evidence that say, no, look, this is what we counted. This is what we had. You signed for it. I would even have whoever you might just have kennel techs. And this gets into who has been authorized. If you guys are going to have kennel techs on the weekend, actually give these animals medication, those kennel techs need to be, kennel workers need to be authorized. So, there's a lot of moving parts when you're taking patients' medication back in for custodial care. I would prefer that you guys don't do it, but there's going to be a time when you have to do it. So when you have to do it, just ensure that you guys are, you're creating the correct structure that you can track it. So, shelter medication, dealing in shelters, we see many different iterations of what a shelter management can look like. Some shelters, or a lot of shelters, will contract out with a local veterinarian to be their vet. Sometimes those veterinarians I've seen are using their own medications when they are working at the shelters. That's technically, if they have a secondary registration, it's probably wrong. So, and most of the time, as you can see in the second paragraph, the only things that we mostly see in shelters is euthanasia drugs and maybe some benzodiazepines as pre-induction and drugs. But still, all of the requirements have to be the same. The record keeping, the storage, nothing can change. Just because it's a shelter doesn't change the rules and the regs for the road. So nothing will, they still have to go through the same inspection process. We also sometimes see euthanasia techs, depending on the state you're in. So some of you might get a job, leave here and get a job for a city as a working in the shelter, and you might go through the training to become a euthanasia tech. What does that mean? That means that you guys are going to be responsible for putting down the majority of the animals under the direction of the veterinarian or under the supervision of the veterinarian. And what does that mean? Does that mean that you and the veterinarian just got on the phone, talked about that case, and she gave you the okay to do it? That could probably be supervision. I would prefer, if you guys go into that way, that you do a FaceTime call so that you can at least have the ability to say, yes, the veterinarian, because this is telemedicine at this point, right? And because of COVID, telemedicine we've had a lot of options opened up for telemedicine. You guys have been doing telemedicine technically for a long time with the Vet Mobility Act, with the ability for vets to travel. But just be aware that shelter medicine, shelter techs, in the eyes of DEA does not look kindly on non-DEA registrants practicing medicine, meaning running that are technically not being supervised. And there are times when euthanasia techs go to the field to perform euthanasias. So, that can be an issue. The Mobility Act in 2014 was passed for DEA veterinarians, not euthanasia techs or techs. We're dealing with this with the AVMA, with some of the euthanasia companies that are constantly out, driving around with their doctors and doing house calls for this stuff. And they want to use specialized techs when they're not available in that state. So just be aware that, that does happen and that those type of jobs are out there for you guys, as a possibility, somewhere down the line. So let me go back. This is drug diversion, correct? Yes, drug diversion. In its basic sense, drug diversion is taking a drug that was prescribed for someone, grandma, for her back pain, and somebody goes into her medicine cabinet and takes that drug just because they want to get high. That's drug diversion at its simplest, and that is what drug diversion is. Someone goes into your veterinary practice and they have an addiction issue, and they put they reach into the tramadol bottle and start taking tramadol. That's drug diversion. So, You know, it is that because that legally is owned by the doctor, the registrant, and that, you know, not only is that drug diversion, you know, that's theft. Unfortunately, we're talking about pennies because those drugs are bought on a wholesale value, but you know, but still we're talking about internal theft of property. The drugs that you will see when you get to the field, these are the common controlled substances that we see that are mostly stolen. The one that is from veterinary medicine probably see stolen the most is tramadol. And but the next highest one, which isn't on the list, and I'm probably going to add that, is gabapentin. Everything else you see here. Now, the one that what's most important on here is buprenorphine. And for those of you that aren't, that don't know much about, addiction medicine, um, methadone used to be the go-to drug for someone who's, who's addicted to opiates. We've been using methadone for a long time. The problem with methadone is it's extremely strong medication. Of course, you can still get high on methadone, and methadone has a long half-life. So you go through a lot of times people go through the day and they just kind of like are drooling a little bit. It's not really conducive. Some people have their methadone in the morning and they're fully functioning people in society, and and they're good for the day. But today we have a newer drug called Suboxone. And Suboxone's main ingredient is buprenorphine in combination with naloxone, which is the drug you guys will have in your facilities in case you have an animal that overdoses during a procedure that's on an opioid. That's the antidose. You bring them antivenom, you can bring them back. That's Narcan. Narcan is naloxone. So buprenorphine is used nowadays for addiction treatment, medication-assisted therapy, whether it's by itself or as Suboxone or in other combinations. So you guys have that drug. It's a go-to drug for someone to steal. It will keep them from getting sick. You have oxycodone, you have hydromorphone, you have morphine, you have drugs that can continue their addiction, and methadone, of course. But just to let you know that that one drug, buprenorphine, is probably the number one addiction drug out there used today. Like I said, the employees that will be you and the people around you are the ones that are going to cause issues for the doctor. Of course, there's doctors that cause their own issues. We've seen plenty of that. But there's a lot more ancillary and people around the doctor, his support staff, that can cause him issues. So, it is, the percentages out there, the people that are suffering from addiction, it's staggering. And if I said 15% of nurses are suffering from some type of addiction, the numbers in the veterinary community are exactly the same, maybe even higher, because you guys have such access, unfettered access to these drugs. So, where a nurse working in a hospital might only have access to her one Pyxis machine on her floor, and she has to go through all sorts of machinations to try and steal, a couple pills a night. So this is an example of how quick internal theft can happen. This was a cat hospital down in Florida. It was really big place because they have a lot of feral cats down in Florida. But this place was a really cool place in the front because that's where everybody could go to do their adoptions. But in the back was the kill shelter and the little clinic. This hallway was wide open. Just realize this place had a contract with the county or the city. They would do work release here. We found out there were people that were from drug court that were working in here, all sorts of things that never should have happened. And this is an example of how quickly somebody can steal something if you're not paying attention. Down at the end of this hallway is where they line everyone up at that door where it says exit. You go through there, and that's where they would do all the euthanasia. But also right through that door is a refrigerator that they kept some controlled substances in. It wasn't locked. So I had the cleaning lady just go in, and I put my business card right next to, I think it was Tilazol or might have been compounded buprenorphine, I don't remember. And I just instructed her just to kind of go in, see if anybody questioned her that want to know what the cleaning lady's doing. And she's a volunteer also. And, what are you going in the refrigerator for? There's no food in there. It's all medications. It's, whatever else they had in there. And that's pretty much took about what, 5 seconds. And then she was done. No one was paying attention. One person looked at her kind of side eye, but that was it. So you have to pay attention. You want to make sure that you don't have areas open to the public. Sometimes the doors cut through, that's fine, but we don't want to make it easy for them. What are some of the internal things that you guys need to be aware of? If you have someone that keeps saying, I'll clean up, I'll clean up after every surgery, I'll clean up. There's a reason why they're going into cleanup. Either they're dumpster diving, they're going into your sharps containers, they're looking for bottles and syringes that weren't finished. Remember, someone who's an addict is going to go to the extreme lengths to ensure that they don't get sick. Those disposal protocols, how things get thrown up, need to be adhered to. Surgery and disposal and waste are some of the biggest areas that we deal with of drug diversion on the human side, and it's no different on the veterinary side. Power of attorneys. A lot of times doctors will grant a power of attorney to one of their staff to do ordering for them, or they won't, or they'll have your staff order for them, but they won't have a power of attorney in place. That's a problem. So, we want to make sure that those are in place. Do you have video? If you do have video, is it looking at the right things? Is video only looking at people's backs? So we want to make sure that, video is important. Without video nowadays, it's almost impossible to figure out who stole what. So if you don't have video's cheap. Make sure you put a couple cameras in that look at your controlled substance storage and where everybody works. Standard operating procedures. You need to have a recipe when you bake your cake, right? You want to make the cake or your brownies the same way every single time. The recipe is your SOP. You want to have training and SOPs that talk about this is how we order drugs. This is how we bring drugs in the facility. This is how we're going to inventory those drugs. This is how we're going to store them. And this is how we're going to administer them and blah, blah, blah. You stick to your SOPs. It's very difficult if DEA comes in to really, to hammer you that you went outside of what you're supposed to be doing, as long as you stay within your parameters. Like I said, if you haven't done background checks, how do you know who you've hired? How do you know that the person you hired is not on parole or probation? We've dealt with those. So, and like I said before, maybe we have to find another job for them in the facility if we can. Otherwise, they're going to have to find a new job. Because if you're on parole or probation for a drug offense, you cannot be working with controlled substances, at least not while you're on parole or probation. And chances are that's going to be very difficult for somebody to eventually give you a second chance. It'll happen. Many doctors and nurses get second and third chances, but it's just something that a real drug arrest or drug theft is probably going to eliminate you from working in your chosen field. So doctor shopping is where someone will go to multiple doctors to try and get the same type of medication. And prior to what we had, the PDMP, the prescription drug monitoring program in place, which now tracks everybody's prescriptions around the country, and it will know if you filled a prescription for Oxycontin from this doctor, and then, I'm trying to fill another Oxycontin from another doctor. It's going to stop that. That's going to stop that one in its tracks, hopefully, as long as the pharmacy is playing around with it. But doctor shopping in the veterinary world is exactly the same. Someone is going to show up at your facility. They're going to know more about a drug than you do. That should be a red flag, number one. Number two, they're going to say, my dog, he only does well on tramadol. Well, I'm the doctor. I'm going to make that decision. Number three, when you start to talk about other options, you're going to get argumentative. You're going to see them just, they have to have this. Of course they need it because they're the one taking it and not the dog. So, that goes hand in hand with animal maiming, people that will hurt their dogs and bring them in for service, knowing that they'll probably get some type of pain relief. So, these are all things that kind of go hand in hand. And, this is exactly, an example. This was one extreme where the doctor had his animal, taught him how to cough. And you'll start to see that in the animal world, there's there's a hydrocodone and cough medicine that is used everywhere. I mean, that's hydrocodone. It's Vicodin. It, certainly for someone that has an addiction, that's going to work for them. There's laws in place for doctor shopping. If you feel that someone's a doctor shopper, call the local police. They'll have a drug unit. Most of them nowadays have a drug diversion investigator that works these cases. File that with them. Let them start to investigate it, because they're going to reach out and they're going to try and find other facilities that have been confronted by this person, and then hopefully they can pick them up and bring them in and investigate the crime that they're committing. We had an example of this in Austin, Texas, where they were afraid to call the DEA for understandably. You don't want to call a bomb strike in on yourself, but they called us, and we were able to negotiate them coming and dealing with it, and it was a very successful result in the long run. So you heard about me talking about red flags. And psychological indicators and understanding what are those signs of opioid abuse, those are important, that you guys kind of have an idea, and and so that you can look at somebody or look at their dog or animal and realize that A, this person looks like they're in some distress, and B, their animal looks like they're maybe in distress. The animal's probably in distress because he's not being medicated correctly. The person's in distress because they're not being medicated correctly, and they're coming to the facility so that they can try and score. So, this is with DEA, this is their warning signs that someone's abusing opioids. And it's everything that I basically talked about. Injuries to the animal that weren't there before, that look suspicious. When someone cuts an animal with a razor blade, it's very easy to tell they've been cut with a razor blade. If they know more about those medications than you do, then that should be a red flag that something's up, and that you should look into this different. And one of the things that we recommend for those patients that doctors haven't, that really need, that are questioning, bring that two things. One, they have to come in every 30 days, and their animals need to start going through some type of urinalysis testing. So we want to make sure that those animals do have the correct amount of medication in them. If you do a drug test on an animal and they have no tramadol, well, we know where the tramadol was going. Number two, we want, that goes down to number two. We want to make sure that the animal's still alive. We want to make sure that we have had numerous examples of people just refilling medication month after month after month to find out the animal's been dead for 6 months. So I know there was something else I was going to say. It went in and out, went in one ear and out the other, sorry. So now we're going to talk drug shortages and why this is important. One of the things that DEA incorrectly made a decision on was their crazy way of looking at the opioid epidemic was, hey, if we just cut off production of opioids, then that's going to stop the opioid epidemic. No, it doesn't stop people that are sick. What they're going to do is they're going to end up going to the street. If they can't get pills, they're going to get them from the dark net. They're going to order stuff off the internet. They're going to buy pills from their drug dealer. And all those pills have what in them? They have fentanyl in them. So if you were just using regular, hydrocodone, and now you feel that you can't get it from your doctor, and you're going to order some from the internet, what's going to happen if you order some hydrocodone that has fentanyl in it? It might be the last time you ever take one of those drugs. So by DEA increasing these quotas, by decreasing their quotas for allowing what they can make, it has caused more problems. And what the other problem that has caused for veterinary medicine is ordering. So if you guys are typically only ordering from one drug supplier, and they are short and they don't have anything for you to buy, you're going to order from someone else. And what happens if you order from 3 locations at one time and you get all of those orders fulfilled at one time? Well, that's a red flag for you. You have just went from ordering, X, and you just went to 3X. So that's going to show up with the DEA. It's not a bad thing as long as you can explain it, but now, you have popped up in their data analytics. So, and the other thing is, when supplies are limited, those initial supplies go to human medicine first, and then what's left makes its way to the veterinary community. As you can see here, here's this is a huge reduction. Part of it also is COVID, people that are in hospitals that are on ventilators, they're on propofol, they're on pain medication. So hydromorphone, which is Dilaudid, that's probably the #1 pain medicine in hospitals when you come out of surgery, outside of morphine. So this is just an example of what they've cut. Okay. And this is exactly what you'll see in your facilities. And these are the drugs that have had their production cut. And all of these you will see. Now, Percocets and hydrocodone, you'll see a lot. Oxycodone itself, you will see in veterinary medicine, not Percocets because there's Tylenol in it, but you will see, oxycodone a lot for larger dogs post-surgery. A couple best practices. For those that get out into the field that become managed, that work their way into management, you have to realize that you have to know who you're hiring. And in today, background checks are a must. They're inexpensive. $75 should be able to get you what you need for one state. For the state of Illinois, obviously you guys are surrounded by a couple other states. You might want to also include those states in your background check. Urinalysis testing. You want to make sure that you have the ability to send somebody for a urine test. This is important, especially when we're trying to ferret out drug diversion. If we're missing a specific drug, we might send everybody in the facility for a drug test. And that's one way. And what we have seen in situations like that, where when we're basically saying, look, tomorrow everybody's going to give a drug test, all of a sudden you have an employee that doesn't come back because they know they're going to fail it. And the same thing goes with background investigations. For those facilities that haven't done background investigations, that wanted to start doing background investigations, you're going to do background investigations on everybody in the facility. So you will then all of a sudden not have a couple people come back to work because they know that they're going to fail that background investigation. So just realize that who you're working with, it's an employee that's going to have the issue. An employee could be a doctor, so just kind of be aware. Again, this is what I'm doing today. Is we're educating. We're giving some training, and this is important. And we have some basic training on our website that gives. It's also CE credits for your basic training, your compliance training, drug diversion, how to do an audit. These are all important functions. So one of the things that you don't want to, the one thing that is your backs up is your security. Do you have a burglar alarm? Do you have cameras set up that you can see what they're supposed to see? Do we have proper storage in place? Is it not just sitting in a drawer? And the authorized employees, the personnel log, who do we have working with these drugs? Talked about SOPs. If you don't have SOPs implemented, then that's the other thing DEA is going to ask for, because they don't believe you. If you just said, yep, I got everything right. I taught everybody, I've been doing this a long time. They don't believe you. They want to see it in paper. So, if you don't have SOPs that talk about how you're going to, like I said, how you're going to bake that cake, then we need to have one put together. And I talked about being proactive. For those places that aren't proactive and they get a visit from the DEA, what does that mean for us? We get that 911 call. Oh my God, we weren't ready. They showed up and they took this, and that, and they basically, they were here for hours, and this is it. We're going to get shut down. Well, no, it's not the end. But we're going to have a lot of work to do to ensure that we meet their expectations, that we realize that the DEA registration that the doctor has is not a right, it's a privilege. And in order to keep that privilege, we have to make sure that we're doing holding up our side of the bargain. So I tried to go through that as fast as I could. I'm going to stop sharing. How do you want to handle some questions and answers, Luke?
There were a couple, there was 2 questions posted in the chat and one in the Q&A. I can read them to you. I don't know if you can see them.
Okay, I see one. Are veterinarians also required to get X waiver training? No, because veterinarians are not involved in addiction treatment. So they do not have to get an X waiver.
And then in the chat, Josh posted 2 different questions.
All right, Josh, let's see. Hi, Luke. All right. Let's see what we got here. Do vet clinics often have dedicated inventory control personnel solely responsible for inventory? Yes, some do. And for those that, grow to that, to that, to that size, it's important to have that person that is your inventory control, manager. But it's a position that you also want to make sure that that person doesn't up and leave you overnight, which we just dealt with a facility down in Florida. And it would have been fine if she up and left and everything was on the level and where it was supposed to be, but she up and left and she hadn't did anything for months. So, that turned into it was a cluster, and it took quite a while to fix that situation. So yeah, so that we do see that, and sometimes it's phenomenal to have somebody who's the inventory manager. The next question is, what is your opinion about requiring Illinois vets to register with Illinois Prescription Monitoring Program? Well, in the state, in Illinois, the veterinary your ISVMA was very successful in challenging the state when they were requiring veterinarians to use the PDMP, and you guys were given special dispensation as not to have to use the PMP, but the PMP works. And I don't really fall for the argument that I went to vet school, so I shouldn't have to practice human psychology or, addiction medicine. All we're asking you to do is, look, you're a doctor at this point. You understand what opioids are, and you understand what benzos are, and you understand what the couple addiction medicines are out there. For you to go in and consult the PMP on a patient's owner that you have suspicions on shouldn't be a big deal. For you to go on there to see that they're currently on tramadol and oxycodone and all these drugs, that should be important to you, right? Because you need to know that when you're sending that dog home with a pile of 90 of 90 pills that could be an opioid. Look, there's ways to deal with these situations. If you really want to, we can do as we deal on the human side. We make those people come in every couple days for another prescription. We give them weekly prescriptions. We only give them medicine for the week. This is, people have to understand that we're in the middle of an opioid epidemic that has literally gotten worse, right? In the middle of the pandemic, this is not something that's going away. Now we have, people that are more addicted than they've ever been before. So, we want to kind of put those, put the backstop up that will give us the best opportunity to maybe stop that. But look, I really wish it was just an option that they could go ahead and register, and if they felt like it, they could go ahead and look. But right now, you guys can't even do that. You can't even register to consult it. And that was the only two questions.
Okay, thank you so much for presenting. I think Kitty is going to want host back.
All right.
Otherwise, thank you so much for presenting and everyone for joining. I hope everyone learned a lot today. I know I did. It was an awesome presentation.
All right, let me figure out how to do the host thing. Oh, I got to go to participants. All right, let's do this and go here. Sorry that I'm make host. There we go. All right, you have been given back hosting duties.
All right, thank you very much. Thank you, Jack. This was a really good presentation.
You're welcome.
And
if anyone has any, I don't know how many people were part of the webinar, but if they have any weird questions or something they didn't want to ask, they can send me an email.
All right, thank you so much. And can we put your email in the chat?
Mm-hmm. Yep. I can do that. I'll do it. There you go.
All right, thank you so much.